Good evening, everybody. Welcome to the Kittitas County Public Hospital District Number 1 Board of Commissioners special meeting, December 3rd at 5 p.m. Welcome everybody at different locations here on Zoom, and to have Amanda, if she could do a roll call for us, and the visitors that we have. Can you hear pretty well?
People should mute if they're.
This is Jason. I can hear pretty well. There's some people who are not muted on Zoom. If they could switch to mute.
It improved greatly, so that's good.
Yeah.
Thank you. Bob Davis,
Here.
Matt Altman,
Here.
Erica Livinell, here. Terry Clark,
Here.
John Ward,
Here.
Julie Peterson, here. Scott Olanter,
Here.
Dr. Martin,
Here.
Amanda Scott,
Here.
Michelle Worrell,
Here.
Terry Barr,
Here.
Jeff Yamada,
Here.
Rhonda Holden,
Here.
Vicki Mateo,
Here.
Andy Olson,
Here.
Dr. O'Brien, and then anyone else that's on the line from KVH admin team, I guess, is all we need, right? Got him.
Great. Thank you. Welcome, everybody. Good to see folks here and on the monitor. Second item on the agenda is the approval of the agenda.
I would move to approve.
Moved by John, second by Terry. All in favor?
Aye.
Consent agenda. Get a motion to approve. Matt,
I'll second.
by John. All in favor?
Aye.
Presentation. So we can go till like 5:30 when we have some public.
Public? Okay. So Michelle is going to be your maestro for the presentation. She has till 5:30. I asked Dr. Davis if I could enlarge the agenda tonight.
Can I pause you just a moment and ask if people are tuning in by Zoom, if they can use their microphones?
Sorry, guys, that's Michelle's dog that decided to talk right when she heard my name.
Hi, Michelle's dog.
So right now we're having a little conversation.
My concern is today's December 3rd. The board doesn't come together again until January 7th. We're hearing a lot in the state and the world about the surge in COVID cases and about the stress that's putting on hospitals. So we have some plans, we have some projections. We're not here to argue about the projection, but it has us concerned. We are anxious about our ability to care for this community and to execute on our mission. We have some great plans to do that, but I wanted you to hear about what the plans were, because this is going to be, if any of this comes to fruition, it's going to be moving very quickly. And we wanted you to have an opportunity to ask about possible outcomes, possible changes that we make. So you'll hear from most of the senior clinical team and administrative team about what our plans are. and get an update on the situation. And at your table, we provided some documents, and I wanted to get these to you. You know, as soon as the paper is no longer warm, they're no longer current. But I wanted you to know that these sorts of reports are the reports, situational reports that we're getting from the state, from our region, from our own COVID clinic, and from our public health department. So this is the sort of information we're getting every week or every day on to. So with that, we've gone out of our way to invite the KVH team to participate in this, as well as the public. And I did in my invitation to the staff here point out that this is the kind of format that we have at employee forums where we have an active chat back and forth, that this was a more formal public meeting. So the chat will not be turned on for this portion of the meeting. So with that said, Vice Michelle, take it away.
All right, so I am sure that Mandy probably has I'm hoping you all can see the presentation up on the screen. And like Julie said, we really, these are some high level issues that are going on, and we really just want to be able to create some conversation with you and answer any questions that you might have. So I'm just kind of going to kick it off. To talk about what's happening with us, we really have to talk about what's happening. We start at the state level. And back in 2018, DOH reconfigured the healthcare response networks. There had previously been 6 or 8 throughout the state. And in July of 2018, they consolidated it to 2. As you can tell, we're in the pink region, the west side of the mountains is the green regions. And these 2 agencies are basically the coordination centers that help compile a lot of the information and feed this information and serve as the dialogue back at the state level. So when you hear us talking about things such as the care phase that we're in, these 2 response networks look at the responses that we're submitting on a daily basis to the state, as well as on different cadence levels to them. And they determine what type of care phase the region is in as a whole. As a part of these networks, regionally, we have what are called DMCCs. They're organizations that are leads in the region. For us, it's Yakima, that if we have difficulty transferring a patient within our region, we can reach out to that DMCC for assistance. The state has created the WMCC, which helps at a statewide level. So if we've exhausted all of our resources to transfer patients through the networks that we have, we can reach out to the WMCC and request assistance. In reverse, they can contact us as well. So if there are other facilities that are looking for space and we have those services available, they may contact us to accept patients.
And
So once
I already warned everyone that I'm not going to be able to keep my mouth shut. Very recently, that was a call that the CEOs in the state of Washington had to make sure that the rural hospitals in the Eastern Washington public hospital districts were prepared to accept transfers. We had done some of that back when VA Memorial was very overwhelmed, so we reached out to make sure they understood that we could take some of their lower acuity patients and help decompress. The reason we participate very enthusiastically in that is we need to keep capacity available to Kittitas County folks who need STEMI and stroke type of care. So it really is a give and take, and Washington State hospitals have a long tradition of really cooperating.
So then we look at what's going on with the state, and this is one of the many dashboards that we can see. This anyone can see. This is actually from the Department of Health, and this gives you just a quick view across the state of where are the hotspots of COVID activity. And you think, why is this important to us? If you look at all of those counties that are in the dark blue that have the highest COVID activity, those are going to be our standard referral patterns and the options of where we would generally send somebody for a STEMI when we're talking about sending over to King County and Harborview. So it's important that we know what's going on with the other levels, and we can dig down when you go onto the DOH site, you can look at trends and see the direction that everybody is going. And the bottom line is everybody's going up. As we move into our region, this is something that our healthcare coalition puts together. This is updated. We submit reports to them twice a week on Tuesdays and Fridays that directly talk about where we are at and what our issues are. We also participate in regional meetings with them via conference call, where we have just very casual conversations on the obstacles we are facing. You'll see in all of these, whether you're looking at percent bed occupancy in the green, acute bed occupancy, or ICU bed occupancy, the darker the color, the higher the volume. And, especially when we start getting down here over in Spokane, or we've got some really high numbers that make it that much more difficult to get patients in and out. So as we get here to Kittitas, I'm going to turn it over to Dr. Martin and let him talk about what we are actually seeing.
So this is a plot of cumulative case counts. What you're really interested in this is the slope of the curve, the rate of increase. And what you don't want to see is a ski jump, which is what this curve is doing as of last week. What we know is that we have seen 378 cases in the county since November 1st. We have a total of 1,249, so roughly 25% of those have been this month. Until this month, we typically would see single-digit new cases per day. We're now routinely running double digits. Today's edition was 27. We're seeing the highest number of cases, and this is a better illustration. This graph, and it's kind of busy. The green is our blue is hospitalized cases, yellow is new cases, red is I need to look at it on my computer because I can't see it up there.
The red is ED volume.
Thank you. And the green is active cases. If you notice those yellow spikes, they all stay below about 15 until you get to the last 5 nights of the case volume per day increasing. And if there's one spike there that got up to that I can't see.
Can we remind people? Sorry, can we remind people to mute the phones, please? Or Mandy, I think you might be able to mute them.
So that's us.
Don't hang it.
The concern in the height of the yellow spikes and what that's going to mean for hospitalizations. This is looking at our inpatient volumes on the lower right, and what we're seeing in the emergency department. We saw a spike back in March. Things calmed down in June, which is actually surprising. July is when we had our outbreaks in our partner facilities. That volume carried us through August. Started back off in September, but then October, November, we saw an increase, and that increase is what prompted action at the state level.
Awesome. Vicki, could you talk about, so this was something we added in today that Dee Dee was sharing. You may have noticed in that earlier graph, while the ED visits were remaining somewhat consistent, the nature of those are different. And I think Vicki was going to touch upon that.
Okay, right. So yeah, we did see that our ED levels pretty much maintained There were some days that were busier than others, but overall, if you average them out, our census didn't really go up. However, the nature of the visits did change. And you can see from this graph, and actually the observation, which is gray, and the inpatient, which is blue, that process to admit a patient to KVH, if they're inpatient or obs, is the same. So really those two can be combined, but it shows you how long it takes a patient to get into our inpatient side. And also the green is the patient that comes into ED, gets treated and gets to go home. Of course, those are a lot faster. There's a lot of workup that needs to be done with those other inpatients and observation patients, as well as the yellow, which is the transfer out. Those patients that are unable to be cared for here because their condition requires a higher level of care and or different equipment, cardiology specialists. So
Vicki, can I jump in here for a sec?
Yeah.
The reason the emergency department has our attention right now is we've seen this case increase in the community, and we're beginning to see those people when they're at home and they're struggling and they're getting concerned about the course of their disease, they're showing up in the emergency department. So there's an uptick in the actual number of positives that we're seeing in the emergency department, but also every patient that presents there is presumed positive. So our staff is going through the same struggle with PPE and the same restrictions as that volume goes up. Is that accurate, Dr. Martin?
Accurate, and the other variable in this that we haven't touched on is back in March, we weren't to expect that this would take a toll on people's emotional health come autumn. And that has proved to be the case. We've seen an increased number in mental health stays in the emergency department. Those stays tend to be longer stays. That's not a 2 or 4 hour stay. That's frequently a 36-hour stay in the emergency department.
And those are patients that frequently we are looking for inpatient placement for. And just like the acute care hospitals, the mental health hospitals, the adolescent psych hospitals are full and very difficult to place to right now. So earlier on, we were very focused on inpatient capacity. We were focused on ventilator capacity. At this moment, the emergency department and throughput in the emergency department and a shorter length of stay has our attention.
Awesome, thank you. Let me just explain this graph and then I'll kick it over to Rhonda and she can talk more in detail about the testing. So what you're looking at here, the blue line is telling you how many tests are coming through the COVID clinic. So you'll see that it's a gradual increase in October and then the spike in November. I think that correlated directly with Governor Inslee's order of quarantine or testing. What you see down here on the red are the number of positives that come out that we're reporting through KVH. So these are strictly KVH numbers, not county numbers. And again, you'll see that we're starting to see a much higher volume in October and November than we were during the stay at home or the earlier times. And then finally, one other thing that we want to make sure that we're watching as these numbers go up within the clinic, so did the pending tests that we are waiting to get results. We had a spike initially and that seems to be coming back down. And I'll let Rhonda take it from there on everything else that's happening within testing.
Right, thank you, Michelle. As Michelle said, we did see quite an increase in testing in the COVID clinic in Ellensburg. It did really correlate to Governor Inslee's proclamation suggesting that people quarantine and get tested prior to travel. We did have people coming in wanting to travel and wanting to know if we could get the testing for them. And of course, we will do that, but we can't guarantee the turnaround time. It's something that we are monitoring really closely. Insight had been doing a great job, pretty much getting us tests back within 24 to 48 hours. But right around Veterans Day, they had a piece of equipment go down. And I think with the holiday and the equipment down, we did start seeing some prolonged test results coming back. But as of right now, they're pretty consistent at 48 hours, which we're happy to see again. They did add a third piece of equipment, so they're able to keep that turnaround time good for us. And the other thing we're monitoring is our patients up in Cleellum. We did go ahead and we opened up a site for testing here so that the residents of Upper County don't have to go down to Ellensburg. They can test in the old urgent care area. We're actually doing it as a drive-by with staff registering them from their car and then greeting them out in the car to do their testing. So we've been pretty busy there too, lots of phone calls. We used to be busy if we had 60 patients, and now we're well over 100 every single day in the Ellensburg clinic.
Rhonda, can I chime in real quick on this? And Mandy, please tell me if I'm wrong on any of this. Something to keep in mind as you see these numbers go up. So, obviously these reports go to public health that we work with very closely. And when positives come in, public health generally makes that contact with the patient, and their goal is to make that contact within 24 hours. I believe you'll see in one of the reports that Julie handed out, that is something that they track. And then our staff call the negative patients and also handle the phone calls that are coming in, which last time I looked, it was just over 14,400 calls that have come into the COVID clinic since we opened in March. So as these numbers are going up within our clinics, there's that direct correlation on activity with the county and their notifications, with the contact tracing, and with Mandy's team, with our employees, and all the follow-up they have to do.
Yes, exactly. I will talk about that in just a minute. Actually, right now, I can talk about it. So that's a good segue into.
Can I jump in real quick?
Yeah.
So this is a report we get everything out of the quality department. It's a running total of the number of tests that have been performed at KVH. In the KVH system to date, we've done more than 12,600 tests. The large majority of those have been done at the COVID clinic. But in addition to that, just the partial information that we have about phone calls, we've made and received 15,000 phone calls out of that clinic, talking people through their symptoms, sort of reassuring people, but also scheduling them and kind of telling them what the current protocol is. So that has been a great asset for us. And again, we work very, very closely on all positives with public health. Turn those over to public. Sorry, Mary.
And that's not a new relationship. So long before COVID, KVH has had a very collaborative relationship with our local health jurisdiction, which is not normal everywhere. Am I crackling? Is that me? What's causing it? Okay. And just for instance, we have representatives from the local health jurisdiction that attend our infection control meeting regularly. We report to them for other infectious diseases like E. coli, salmonella, or rabies. They direct us on our other infectious disease exposures as well, like whooping cough or meningitis. So from the very first case, we've partnered to make sure that we have timely notifications, testing, data reporting, and patient and staff support, like they alluded to, right? Supporting patients that are positive, making sure staff are supported, and this still continues. So we're part of the incident management team, and that has a big effect. Several times over the past 2 weeks, I've been thanked by our partners that are in incident management team, and we've thanked them right back for the service, the resources, the collaboration, like the COVID clinic, that all of our county has benefited from. So this is unique in Kittitas County, and KVH is a part of that. So what happens is at least daily, KVH reports to the public health jurisdiction all of those people tested at KVH. We call our own negative results, as Michelle said, and the health officer or case and contacts folks, they call positives to interview them. So they interview them, but then they also have frequent calls to check in on the positive cases and make sure that they have the resources they need, the support. How are they doing? Do they need more care? They notify identified close contacts to quarantine. They work with employers and schools and agencies to make sure that people are able to return to work or school safely. I was told by them recently that only a handful of counties in our states still are doing this type of case and contact investigation, if they have ever done it. So again,
Hey, Mandy,
this is very unique. Yeah.
I'm just going to jump in real quick. We have some phone lines that aren't muted. I think somebody in a car and an 837 number. If you guys can please check your lines and make sure that they're muted, that would be super great. Thank you.
Thanks. So like I said, again, we're unique. Our health department is doing this, this kind of contact investigation. Yeah, we're hearing the door. Somebody's door is ajar. Please mute yourself. Thank you. So right now, as of their most recent report, they 72% of positives were contacted within 24 hours. That was for the week of November 15th through the 21st. The week before, they had reached 87% within 24 hours. They continue to reach out and contact them. And this is just incredible numbers compared to other counties, especially with this increasing volume. They're at 100% for potential contacts within 48 hours of getting that notification that someone was a close contact of a positive. So that's really incredible. And I think that is part of the reason we're doing so well in this county, as well as can be. So what KVH is in particular doing that is very similar to that is Anna Scarlett and I are part of the incident management team as safety officers. And so what we do is we review the updated proclamations, documents, whatever, and help provide guidance to both KVH and other agencies about PPE, infection control standards, exclusions, quarantines. We also look out for any safety issues that there might be or that could affect the incident management team, such as when they're doing large testing, making sure the staff doing that at the county or those resources are safe. And then we also partner for the protection of our patients and employees. So Anna and I meet with Dr. Larson every week. We are in constant communication with him on top of that about potential exposures. So we look at each and every case that is positive at KVH to see if staff have had contact with that person. So that's that graph down there in the bottom right corner. We look for exposure risk and we make sure we notify employees that they took care of a positive patient. So you can see there in November, we had 611 contacts with employees related to all of these positive tests. The other thing we do is when we do have positive staff or staff that have been exposed, most frequently too in the community, not at KVH where they've been exposed. We do assessments with them for their need for testing, potential exposure at work, potential exposures to patients and staff, and their need for isolation or quarantine. And then we also have a responsibility to make sure we're identifying if we have any potential outbreaks. And I'm happy to say that a lot of that is just reviewing and checking. It's not actual incidents that we've had to deal with. So it's a lot of double checking. So you can see, we also get employees who have symptoms and they're not sure what to do. And it has nothing to do with a potential exposure other than we want to make sure we prevent them from bringing that to work. So you can see on this other graph where the blue bar is the number of employees who have been tested in that month. The orange are the numbers that are negative. The yellow or the gray, excuse me, are the numbers positive. And the yellow is those that are excluded from work. So it could be because they're positive or it could be because they had a contact and they need to quarantine. And so they're not allowed to be at work. So you can see we did have a big bump in July and August, the very beginning of August, really. And then October really felt like it was, big month. And then we had November too, and really knocked it out there. So those numbers, there's 83 tested. 68 were negative, and 15 were positive in November. And we've had 2 so far in December.
Awesome.
So I think,
Amanda, can you talk about how we pair up with our unions in these conversations?
Yeah.
yeah, I'm going to let Vicki talk about that. But just the one thing I'd like to say about it is I've been away from the bedside for quite some time. And it's very gratifying to do this work for our employees and to provide guidance and reassurance to them, because we have had this many cases that we've reviewed, and it's amazing. It can be complex, and scary to anybody, and it's nice to provide that care and comfort to our own employees. So we meet, Anna and I meet routinely with HR to check in about our employees, as well as our workplace health department. But I know Vicki and Amanda have also been doing a ton of work with our employees and the unions.
Right.
Can
We
we,
address this every month. We have a. Whoops.
Yes.
Can you hold on a
yeah,
second?
so we still have a ways to go.
We do, yes.
Okay. I mean, we're dealing with unprecedented things and unprecedented efforts. So, and I'm sure the board has a lot of questions, but we have committed to public comments. I know Rich Elliott has a comment he'd like to make, and like to welcome him. And I'm not sure if we have any other public comments, but we do typically keep the public comments to 3 minutes, and typically the board doesn't respond. But Rich, are you there?
Yeah, can you hear me?
Yeah, you come across very.
This sort of echoes the presentation that's given. I just wanted to sort of give you guys some feedback from my perspective. I've been working on the incident management team here, and actually on incident management teams for 25 to 30 years. I worked for a few weeks over at Camp Murray in the Unified Area Command at the state EOC on this same issue. And so I think I have some perspective for around Washington State and how EMS systems work with hospitals and how hospitals work in their communities. And I just wanted to thank the board specifically. Your staff has been doing an outstanding job. I think Mandy mentioned that, you know, the level of cooperation and collaboration you guys have with public health, with EMS, is not seen in many communities. And it's been particularly helpful, I think, with COVID. I think the COVID clinic, I think the decisions that, you know, Dr. Martin, Julie, all of your senior staff are making are allowing people in your system to sort of mitigate the impacts to our community, which I'm 100% committed or convinced would be significantly worse if you hadn't taken those steps and taken those steps proactively. I know it's difficult because a lot of this stuff is a leap of faith and not getting reimbursed, but it's paying dividends. And I just wanted to sort of say that from, you know, my perspective. I sort of sit somewhat objectively, kind of on the fringe of the system. Right now, we're working with Mandy and Anna very specifically on the vaccine planning, and that effort's going well. We manage relationships with the emergency department, with DD, Dr. Lindsay, and I just wanted to say thank you, because I think it's paying huge dividends, and I don't think the community necessarily fully appreciates that, because they don't know what doesn't go bad. All they know is that, you know, they see the things that are impacting them, but they don't see how bad it could be. And I'm very much convinced that you guys have done a lot to keep that from happening. So thank you.
Thank you, Rich. We appreciate your comment. Are there any other comments? Oh, if there's no other comments, we'll go ahead and continue. Mandy?
I think we were to Amanda.
Yeah.
Amanda, okay.
Yeah. So
Welcome to my.
Yeah.
there's a few of us. Thank you and hello. Yes, there was a comment, transition talking about our relationship with our labor unions and how we're getting staff engagement and feedback during this time as well. And we just want to say we believe we have very collaborative relationships, and we've really appreciated our union nurse conference committee and our Teamsters representatives during this time. So really looking back at throughout the year, we've been able to review our policies together, challenge each other on things that are happening in the industry. We've negotiated several memorandums of understanding for things that nobody anticipated during COVID, so that we could really outline some clear expectations and policies. And we've offered additional meetings and continued our meetings virtually with our union representatives, and offered also to involve them as well in our campaigns and communications around keeping each other safe. So again, just a thank you and collaborative relationships there. We've also continued some staff feedback and just again, some targeted surveys of some ways that we can really hear from our staff for planning purposes. We did some childcare work groups and some surveys around that time when that was a very big issue and not an unknown of what was going to happen in the school year. And we also did a recent survey about vaccine planning and what the perceptions of our staff are around vaccine planning. So
I did feed the dogs, hon.
Okay. So I think somebody else is unmuted there. So we'll just everyone double check. And so again, just thank you to our staff for providing us the input we need, and to our labor union partners for the collaborative relationships. And Vicki, if you have any comments on that as well, I'll hand it over to you.
I think you hit that right where it needed to be. We do meet monthly on a regular basis with the union reps and staff as well. So a lot of issues are brought up at that meeting, and we try to mitigate them, or at least come to solutions together on how to deal with those issues. So I feel the same way as Amanda. I think we just need to keep talking.
Vicki, in one of the earlier slides, we were showing the bed occupancy, but can you talk a little bit about how no matter how many beds we have, it doesn't matter about what matters is how many staff we have. Can you talk about just kind of like what you're seeing on the floor with staff and challenges that they might be facing?
Sure. Most of the impact we're seeing currently is in the emergency department. Some days they see up to 7 suspicious patients that could be COVID. And so that really takes up the resources when you're talking about manpower, because it's a full donning and doffing of all the PPE, and usually a one-to-one, because you want to leave that same individual in there and limit your other staff to other patients. So we have seen in the ED that's really been a stressor on the staff. We have a list. I think Dee today was able to get another additional staff member through our agency. We float additional staff there when we're able to, because it's just taking more manpower to care for those patients. And they are, they're sicker. They're sicker when they get here. So that really takes a lot of staff to care for them. On the inpatient side, it's a little different because we know if a patient's coming in, whether they're COVID positive or not, so we can kind of plan for that. We do have a plan of where those patients should be and how to care for them. So it's a little different than the ED, where we don't have control over who shows up at the door.
Yeah, and I think, a lot of the things that we're also hearing through conversations is, I don't have the day count, believe it or not, but we're 9 months into this. And so while our staff are trained on emergent situations and crisis and things like this, this is one that has gone longer than anyone has expected. There's so much uncertainties to it. And it's not something that we can just say, okay, we're going to take these measures for the next 30 days and we know it's going to be done. And so there's that emotional toll. It's that same toll that's going on with the public, and the fear and the uncertainty is going on with our staff. And the outcry and the pain that the public feels not being able to visit loved ones and things like that affect the staff also in very unique ways and trying to work through it. So all those percentages from the state numbers that we see are very key, but we have to pay very particular attention to our staff and how we can keep them satisfied and healthy and moving, not just through the month of December, but through 2021 as well. So we really have to look long-term on that.
Michelle, I have a quick question, if that's all right.
Of course.
This is Matt. I don't know if this is for Vicki or for Dr. Martin, but I mean, I read something about this, but I'd like to get it from the people who are actually out there. What's the current, like when you say treatment plan and stuff like that, what are you doing exactly? I know putting them on a ventilator is not what we do now. So what is it that's done specifically, and what's taking all the time? I'm just trying to understand, like, what happens on the floor.
Most of the time component is nursing care. It's the hands-on and what it takes to get in and out of the room. Treatment, and we'll come to what this means in terms of planning, has actually become fairly minimalistic. Most of the drugs that showed early promise, including remdesivir and convalescent plasma, we're now seeing more moderate results. For moderate to severe illness, dexamethasone, high-flow oxygen, proning. Proning is probably the single biggest labor piece and probably the biggest reason for a patient needing to be in the hospital, frankly. A lot of the care before they get to the hospital is supportive and reassurance. I feel short of breath. Well, but we gave you a pulse oxygen, you're still satting 93%. We'll keep in touch, we'll write this out. And that work that public health has been doing and that we've been trying to support, I think probably has done more to protect us and protect our ability to serve than any pharmacologic measure. To a large extent, the treatment of this disease has become an exercise in minimalism. Some patients do progress to the point where they need ventilation or ECMO, extracorporeal membrane oxygenation. The problem with ECMO is that's an incredibly scarce resource. We had a patient pre-COVID, or at the beginning of COVID, that tested negative, that wound up going from here to Seattle to Portland because that was the nearest available ECMO unit. There is capacity scattered around in Seattle and Tacoma, but it's a thin resource. We're still learning more, but the care is largely supportive.
Right.
Thanks, Dr. Martin.
Vicki, did you add to what Dr. Martin said?
Yes, totally. A lot of it's emotional. So you have someone coming in very anxious, very short of breath, hears everything bad about COVID, and honestly, they are scared, they're frightened. We offer them oxygen, we can give them some medication, we treat them with the medicines, Dr. Martin mentioned, but most of it is supportive and watching. And do you need more oxygen? Regulating the oxygen so that their saturations are well, just being with them, helping them communicate with their families because there's no one there, they're by themselves. So it's very emotionally time consuming, and it's for the nurse to, every time they go in and out of that room, they have to take off and on all of their PPE. And sometimes, we have someone outside the door handing them things so that doesn't happen, which is another resource. So it's taking a toll. The difference between the inpatient and the ER is that on the inpatient side, we haven't seen, I think there was 1 or 2 days where we had more than 2 patients that were COVID positive. So we don't see the amount that they see in the emergency room.
So can I just, again, one of the reasons that we're here is, if you'll recall, the slope of the positives in the county. These people are experiencing these symptoms with their families, with their caregivers over 10 and 14 days. And to that partnership with public health has been trying to stay in front of that anxiety for people recovering at home. Their resources, as positives have increased, have been stretched thinner and thinner. We're going to see what we can do to support them in that work, because again, We think that's critical to keeping these recovering patients out of the emergency department unless they absolutely need to be in the emergency department. But as those positives have gone up, that churn, that general anxiety in the community is showing up in the emergency department, and the slope of that is intensifying. And again, every patient who comes to the ED is presumed positive. So it's, and you know, to Amanda's point about working so closely with our staff, and Michelle talking about the resource that we're protecting is no longer beds, it's staff. We're 9 months into this. We have our own staff that's been excluded, just like every other employer, because they, you know, were exposed in the community or did whatever. So it's a very, very careful balance, and an assessment that we're doing on a, you know, every morning we're assessing our capacity and what our staff and our weaknesses are. But that's why we're here tonight, because of all the moving parts and because of that slope of positives that Dr. Martin showed you.
Okay, thank you.
Great. Dr. Martin, do you want to continue the conversation with our collaboration on CWU?
So one of the things that we've been very cognizant of is the movement of students in and out of the community, and often coming from areas where there's far higher incidence rates than what we have here locally. We've been concerned for the students. We've been more concerned about their exposure to staff. Public health tells us they've seen very little student to staff transmission or vice versa. But we did have significant outbreaks when students first came back. Currently, CWU has had 218 cases. They currently are doing contact tracing and care for 218 is roughly a sixth of what we've seen in the county to date. We meet with them. Julie and I meet with President Gaudino and Greg, and I'm blanking on his last name.
Don't look at me.
And Dr. Larson, as to what capacity is, what the university's ability is to isolate students on campus, and also what they have made themselves available as a resource should we need an alternative care facility, someplace to do isolation and quarantine, or someplace to house recuperating patients, or conceivably someplace to house patients on comfort care. One of the things that I think is interesting about this and the data that we've collected in working with the university is on the bottom right, the orange are CWU student positives by month. In September, we had students come back and they were all glad to see each other. In October, we had an uptick in cases. The university did a good job of educating and working with students to be better about social distancing, better about maintaining face coverings, better about washing their hands, and they bent their curve. In the community, so we've gone from September and October, where essentially half of the disease activity in the county was on campus, to November, where they represent about 10%. That's cause for hope. In front of you, you have a report from the Public Health Department, and on page 3 is a chart that Julie was alluding to. This is our, and the reason I'm bringing this up is because we're getting to the point now of starting to talk about projections. This is a chart that's very difficult to interpret. It shows our case rate for 100,000 population over the last 14 days. And we can see it growing exponentially until the Thanksgiving weekend. And then I can't tell you if that plateau is because there were fewer cases or because there was fewer testing because of less testing because of the holiday. If the governor's proclamation on November 16th had the same effect that it did in May, this is about when you would expect to see the curve start to flatten. If we, as a population, undid some of that good work by putting millions of people's people on airplanes over Thanksgiving. We'll see that next week. This is a projection from the Institute for Disease Modeling, which is housed at the University of Washington, and given us a lot of the information that we use for decision-making locally, state level. So what this is hospitalizations over time. And you see the peak in April, and then you see what happened when people started when we started locking down, when we started restricting gatherings. And we did pretty good through the summer. And then you start to see it swing up. So these are people who have studied this and studied other infectious diseases forever. The two models that they project, the first is the one in red, which is if we continue exponential disease growth, by the end of the year, we can expect to see hospitalizations that are roughly 3 times what we saw in April. Roughly 3 times or 4 times what we're seeing currently. The blue line is if the governor's proclamation has the same effect on the curve this time that it did in April, we might be able to flatten the curve enough that at the end of the year, we are only seeing hospitalizations at the same rate that we saw at the peak of the first wave in April and May.
So you can pick whichever projection. I mean, somewhere in there is going to be real. We're not comfortable with any of the projections. Best case, worst case, we're still looking at a very busy time.
One of the things that the board has heard from Julie and I from the beginning of this is that on about day 3, we realized that we were not going to get it right. We were either going to over-prepare or under-prepare. And it was a very conscious decision to over-prepare. This is what we've seen, but what we really want to talk about here is what are the potential impacts based on what we see over the coming weeks. I'll point out that we don't expect to have widespread vaccination until optimistically February, realistically probably sometime in the spring, which means that we're going to be relying on the same tools that we've had for the last 10 months to get us through the next 3 or 4. One of the things that you heard is we talked about DMCC and WMCC, coordinating care across the state. Those models and those organizations were all based on the assumption that there was a disaster somewhere. A volcano blew, an earthquake hit, there was a mass casualty incident. How do we move staff and resources from the areas of surplus to the areas of need? And that worked in the winter and the spring and into the summer, when we could say Yakima needs help. We could say New York needs help. We could move resources there. One of the potential impacts that we're looking at is that in this phase, we are all looking at hitting crisis at about the same time. One of the things that Julie alluded to was the spirit of cooperation in the state, and the hospitals in this state have made a pledge to each other that nobody is going to be alone in crisis. We will redistribute resources, we will redistribute patients as best we can until the well's empty. And we hope that we never get there. The same thing applies to moving staff. When we opened the ACF, we were able to borrow staff from around the state to help us staff that. Those folks are now dealing with issues in their own communities.
So can I jump in here, Dr. M?
Yep.
So I was just like you were mentioning how the state has made the commitment that no one hospital is going to go into crisis. That dovetails really nicely into how KVH has done our planning and modified its surge planning from what we thought we were going to see at the beginning of March to where we are now. and how each of the different aspects of our operations are going to bend and mold and help during this surge. And
So
that's kind of what what's that?
I was just going to say, so for instance, we have physicians that are prepared to step in as surplus hospitalists so that our hospitalists can function as intensivists.
Exactly.
Consolidate clinic operations so that we have staff available to help in the hospital. If we get to the point, we are now thinking that if we have to modify or suspend non-urgent procedures, the purpose of that is going to be more to mobilize staff to help elsewhere in the hospital. We're going to have to look inward to figure out how to handle it.
Carrie, can you jump in and talk about the clinics and planning that you've done there?
Yes, thank you, Michelle. Good evening, everybody. To Dr. Martin's point, in March, we started having a very long conversation about the surge planning on how the clinics could support the hospital. What we didn't do is really plan on, at that point, there wasn't a lot of patients coming into the clinic. So we said, gosh, we've got the resources, here we go. This one little bullet point on that slide, that clinic operations and kind of what we've done with that, doesn't reflect the time and the attention that myself, the managers, providers, and staff have put into our contingency plan to make sure that we're prepared for what may happen. And what we're thinking, or what we've planned around, is around 3 Ps, and that is people, process, and preparation. And looking at, in particular, people, we need to think about how this is going to impact our staff. So if our clinic staff is impacted, our patient service representatives, we only have 2 patient service representatives for one of our largest clinics. What do we do about that? What's our staffing matrix? What is our minimum staffing volumes? What do we do in terms of reducing, removing, or redeploying students that we may currently already have working in the clinics? Maybe how can we have them assist maybe in a different way? And then, and really focusing on how patient service representatives for other departments can, so maybe from patient financial services, how we can borrow that staff to really maintain our focus on maintaining access for our patients, which is our ultimate goal. In preparation, we've been thinking a lot about our physical adjustments. Where do we go if women's health clinic is impacted and we don't have enough medical assistants or RNs or patient service representatives to be able to maintain access for patients? And so our 13-page contingency plan reflects all of that in terms of, for an example, if women's health is impacted, we would move them and embed them into family medicine Ellensburg. And with that, as you can imagine, comes a lot of planning. So what does that mean for medication that they need, certain equipment that is needed, supplies, again, the type of staffing, computers, phones, all of that stuff, signage. Michelle loves that one. And so just really working with all of the other departments to make sure that we're in the prone to run position if we need to deploy any of this. And in preparing for this and in getting ready, we have been able to implement some things like a patient service representative manual. This is a manual that can be used at any clinic, and or each clinic has their own manuals. And so that if I'm a patient service representative at Women's Health, but I am now being deployed to work in ENT, no worries, there's a manual there that I can follow. And so this way the patient can really have the same type of experience that they would have with the regular staff. We've also redeployed our rooming criteria. And so this is our medical assistant rooming criteria. So again, we have some standardization around how folks are being checked in and hoping that the patient doesn't feel the impact of any changes that happen with our staffing. Another cool thing is,
you have, Carrie, can I jump in? So if you have an appointment to get your kids immunized on December 21st, to go to the Medical Arts Center, you may very well be directed to Family Medicine Ellensburg. And the thing that keeps people like Carrie Barr and Mandy Olson awake at night is 5 PSRs who all commute together from somewhere in Yakima, and one of them comes up positive, and all 5 of them are excluded from work. So we're talking here about contingency planning around staff shortages and staff being moved out. So being able to move those resources around so patients that we need to see in the ambulatory setting, we can continue to see.
And we've
Sorry,
been,
Carrie.
yeah, we've been really close on having to deploy this. The last couple of weeks have been kind of tight with staff, but we're in a good place. Although I probably just wrote the devil on the wall by saying that, but we're in a really good place. All the staff is healthy and back to work. Some other cool things that we've been able to get with this is e-faxing. So that is what we had a patient service representative who came up and said, you know, here's a really cool idea with the contingency plan is if we had faxing that e-faxing across the board. So regardless of where I'm at, I can go to this other clinic and electronically be able to help out. So maybe I don't need to actually go physically to that space. So again, this is the great work that happens when you think about all these good ideas and you lay them out on paper, but then you actually give those ideas to the people doing the work, and you know, all the great information and feedback that comes back has been really helpful to morph this plan. So I think then just thinking the last piece about the last P is process. And again, that's shifting clinics to the new location. We don't want to postpone any wellness visits. We know how important those are, but we will keep an eye on those. There's putting some triggers in place to make sure we know when we need to kind of postpone or delay that care. But again, that's when things have gone really bad. But what we also want to do is make sure that we're increasing our chronic care management visits. And that is the service that the patient actually stays at home, and their nursing visits. We call them and we're checking in on them. And there's just not a better time to be doing that, to really be checking in on our patients where they're at, and that's at home. So anyway, I summarized, like I said, a 13-page document into just a few minutes, but
awesome. Thank you.
Thank you, Michelle.
So the next bullet on there, we talk about non-emergent surgeries, and it's or procedures actually is probably what we should put there. And just an example around that, we spent a little over an hour today going through the 35 plus items through the governor's recent proclamations, just doing a crosswalk to make sure, are we meeting the measures that we need to? Do we have the processes in place to look at this on a regular basis? Because what's really driving that non-emergent procedure question is, do we have the staffing, and do we have adequate protection for our staffing and our patients in order to move forward with that? And when we look at that, it actually is a trickle down between those staff that are in our surgical outpatient unit. Can they be redeployed? Do they need to be redeployed to other areas where there might be higher patient volumes? Looking at our urgent care clinic in Cle Elum, and if that's something, if it gets critical staffing levels up there, do we need to close urgent care and keep FMCE open 7 days a week? So really thinking out of the box, and Vicki and her team has been doing a lot of work in that area. Vicki, do you want to talk about that?
Sure. We went back, I think, a couple of weeks ago and revisited our surge plan that we had done initially. And while all of that seemed well and good, we had focused earlier on ventilator care and those critical patients, COVID patients that would be here for for a long period of time. And that still could be the possibility. And we are prepared to do that. But I think in looking at our population and the patients we're seeing, that prolonged inpatient care, especially on med surg or CCU of those patients, helping them through that disease without intubation is more what we're seeing. And that takes manpower. If you have one patient that stays 10 days and you have one patient come in every day that stays 10 days, you're going to fill up your unit really quickly. And that takes staff. We are prepared to double up and have capacity to do that, but we only have as much capacity as we do nursing staff. And that goes along with the PCTs and the secretaries and everyone else that helps support the nurses. So in looking at that, Amy and surgery look at our inpatient surgeries that are scheduled pretty much every day so that we can forecast those patients as well as our medical patients. We look at those, we look at PPE every day. We look at our staffing every day. If it comes to the point that we do need to look at curtailing our surgery department, we can do that, but it would be more for the utilization of the nursing staff and support staff more than bed.
And Vicki, can I jump in?
Absolutely.
This is Julie.
Sure.
Unlike the governor's new proclamation is as final, I think, as it's ever going to get around non-emergent procedures. Unlike in April, these decisions have been left up to the facilities and to the regions to a lesser extent. So in April, he shut down non-emergent procedures throughout the state, or March, whenever it was. And so we had no choice. We didn't have any discretion around that. This time it's up to us. And again, we have our eyes on the mission of taking care of the community, but supporting our staff as well. We're going to have to pick and choose at some point, perhaps between now and just the next few weeks, which services can we continue to provide. And as Vicki pointed out, we may, our staff, we did a lot of cross-training a few months ago. We've talked through these redeployments with our bargaining units, with an eye to making sure we have this talent and these resources where they need to be. So we may be closing down our OR for non-emergent procedures again. We're going to do that, keep people redeployed and get patients taken care of. And it's going to be done daily as an assessment about staff and PPE and beds and what we're seeing.
So I have a question about that. Again, I don't know if this is for Vicki or Dr. Martin, but what's the average length of stay for a COVID patient here and, sort of nationally? Are we on track with that? Or do you guys know?
Vicki?
This is Vicki. The ones that we have seen here in the inpatient is anywhere from a minimum of probably 6 days to 10. And those are the patients that we support pretty much with oxygen and medication. They are not ventilated. The ventilated patients are a lot more complex and a lot sicker and require a lot different time. But we're seeing the patients we see here a minimum of 6 days to about 8 to 10.
And can I just point out, we are not transferring out patients because they need ventilators. So we are, we have, I believe, transferred 2 COVID patients since this all began. So we are caring for our community when they present here for acute care. Right, Vicki?
Yes, we have. And when Yakima was so inundated, we had taken several from them as well.
Right. And this ties back to, go ahead.
This is Erica. I was going to ask if they're not being transferred for ventilator needs, is there a basic need that they're being transferred for?
ECMO.
Oh, it is ECMO. Okay.
Yeah, the ECMO. There are patients that we do transfer for other reasons that are incidentally COVID positive as well. But normally it's because they've had a heart attack or they need some service that we can't provide.
which ties in perfectly to, as we look through the emergency services and then we think back to why do we care about what the rest of the state is doing. This is where it really begins to impact us as everyone is reaching these peaks at the same time. I know Dr. Lindsay shared a story a week or two ago that just because of the pure volumes of what was going on over at Harborview, it was 4 hours to get a call back. And so placement for patients is becoming extremely difficult, much more time consuming, both for the patient and for the staff to find the appropriate place to go because everyone is filling at the same time. And so I know any request that we get, if for some reason we cannot accept that patient, that review goes up to senior level. So Julie is always able to answer that question at the state level of we called you and you can't accept, why? And I believe that's only happened twice, and that's only happened because we did not have the service they were looking for. And so what's happening in the state and what's happening in our surrounding counties plays a very key role on what's happening in our emergency room. And then at the core of all of this, or one of the things that just supports everything, is what our supply chain looks like. Morgan has been fabulous with her team. This is part of the data that we report every single day to both the state and to the feds. And you know, we hear about the N95 mask, but tomorrow it might be needles that are difficult to get in. We had a good supply chain for a rapid PCR test for a while, then it became inconsistent. It looks like it might be getting a little bit better. So these are things that we are continually watching and forecasting so that nothing sneaks up on us, and we're doing everything we can to make sure we can continue to care for everyone that comes in the facility. Anybody want to add anything to that? All right. So then the next thing that we can move into is vaccine planning. Mandy?
Yeah, so it's really great that Rich is here because he is leading the branch that in the incident management team that at the county level is responsible for the COVID vaccine planning. And he and Anna Scarlett, who is our infection control employee health coordinator, are partnering for that in the county, and then Anna specifically at KVH. So there's some things we have control over in this, and there's a lot we don't. It's up to the state or, you know, how the trials are going and when things will be available. As Amanda mentioned, we have surveyed staff about their willingness to receive the vaccine. And of the 200 plus employees that responded, 60% did say they were interested in receiving the vaccine. We've helped within the county to help enroll other agencies, make sure that throughout the county, we're prepared to receive the vaccine if and when that happens. We know about the counts of the different tiers of individuals within the different agencies and patient populations as much as we can. We don't yet know what exactly those priority tiers will work out to be. They're still in draft, but we're doing all that we can to anticipate that. We've inventoried equipment and manpower capabilities throughout the county. And so the other thing we've done is we did receive confirmation today that KVH, the hospital and the KVH Internal Medicine Clinic are enrolled. So they're ready to receive vaccine. Like I said, much of this is out of our control, but we are as ready as we can be for when that vaccine is available to us, for our county, for our healthcare workers. The next thing that we will focus on is making sure our providers have all the information they need to be that trusted source of information for our patients, that they are comfortable recommending it when it comes to public distribution. So we've already been working with our clinic providers to understand what information they need, how comfortable they are, you know, how we can support them in this initiative. So I think we really are positioned to be able to provide as much vaccine as we get.
Mandy, I have a quick question. This is Matt. When you surveyed the staff, what was that number you had for the percentage you were willing to receive it?
60% of, and Amanda can correct me, I think it was 220-ish employees.
That's correct, yeah.
Are we gonna have to come up with some kind of policy like we did with the flu vaccine about masking? I mean, we have mandatory masking already. Is there anything we need to do?
You know, back to communication and partnering, I think as this develops, we're going to be calling our bargaining units, we're going to be calling the unions and saying, what's best practice? What are you hearing? How are you moving? What are you recommending to your members? It's going to, you know, making a vaccine like this mandatory, I think, is a blunt instrument. We're better served with communication and encouraging and talking to people. But to Mandy's point, I think some of this may come down as a mandate from outside of KVH. So
bear in mind that as these vaccines are coming out, they've been given to somewhere between 30 and 50,000 people. That's actually a large phase 3 trial. There are some drugs that make it to market with a phase 3 trial of 5,000. Which means, and that's one of the reasons that we have aftermarket surveillance of any new agent, because you can't know what the 1 in a million side effect is until you've given it to 1 million people. So I think some apprehension is natural, and I get it. What our team has heard me say time and again is that I will do everything I can to make sure that everybody that wants to get vaccinated gets vaccinated, and once everybody who wants to get vaccinated gets theirs, I'm next.
Do we have,
Thank you.
all the vaccines that require special temperature? Do we have that kind of stuff for the population? Or
Andy, you want to talk about the storage, or shall I?
Well, part of what's hard to talk about is we don't know which vaccine we'll get. So there's different criteria of equipment you need, reconstitution, depending on which vaccine. So, I mean, the state has asked us to inventory all of our freezers, refrigerators, our temperature monitoring, and we have supplied all that information to the state so that they know our capabilities. But they also are asking that people don't go out and purchase things at this point, because a lot of it they're planning on supplying, whether it's ultra cold storage or what that might be.
So
and Mandy, correct me if I was just going to say, correct me if I'm wrong, but this is the work that you and Rich and Anna are working on a county level.
Yes, as well as a KVH level. So individual agencies have to enroll themselves, and we want as many as possible too, even if we know first stages might be, the majority of it might be KVH or KVH partnering with other agencies to get distributed out to them.
Just in broad terms, of the 3 vaccines, the first one that'll be available is the Pfizer product. We don't know if we'll see any of that. It ships in lots of 975 doses. It is shipped in dry ice and insulated containers that are monitored, that have GPS trackers in them. In the original packaging, you can reload the dry ice 3 times and get 20 days life out of the shipment. If you have ultra cold storage at 80 degrees below, you can keep it for up to 6 months. But even just in the packaging, you've got 20 days. That vaccine requires a first dose and then a second dose 21 days later, which means you can't use anything from the first shipment for the second dose. The next vaccine will be the Moderna product. That is merely low temperature, minus 20 centigrade. So fairly conventional freezers will handle it. That one is a split dose regimen with the second dose 28 days after the initial dose. The third product we'll see is the AstraZeneca AZD 1222, which is also a split dose regimen. The first dose is a half dose or a mini dose, and then 28 days later you get a full dose. And the reason they figured that out was because they had a manufacturing snafu in the study, and about half the subjects got an incorrect first dose and got better protection than the folks that were in the study protocol.
So a lot of that is to say, we've had to work very hard to let go of the concept that we're going to have control and focus our energy on being prepared and being able to move in whatever direction, whatever supply we end up getting. And again, we're part of this. We're not driving this. So that's exhausting work. And you know, it's a joke, but I think we all have our eye on December 31st, thinking when 2020 is over, somehow magically is all going to get better.
Yeah.
And we know that's not the case. So I don't think I've ever asked the board for this kind of time for a presentation, and I do feel it's that important. These are conversations we have been having all the time. I want you to feel assured that we're doing everything we can to prepare for whatever comes. We are doing everything we can to support the staff that's taking care of those patients. And people are tired, your staff is tired, the community is tired. I just want you to know a tremendous amount of energy is going into this, a tremendous amount of planning. So whatever comes, we'll be there.
Yeah, I mean, there's been so much energy and effort. I mean, even just watching this presentation, just see where we've been and where we're at right now, and just the whole uncertainty and the anxiety that's out there, and just very much appreciate the senior leadership just, you know, presenting to us, kind of telling us where we're at with the surge. What are we doing this time around? What's different this time around, this versus the first time? When you look at numbers like 12,000 people who've been tested, that's what, quarter of the population of the county has been tested in the last 9 months. I mean, that's amazing, right? That we're
Is it possible that some people have been tested twice or more?
Yeah.
Yeah, so there's definitely some variation there, but it is like impressive. That's a lot of testing.
Well, and
go into.
it is, we make it as barrier-free as we possibly can. We educate about what, you know, when they should be tested and symptoms and things like that, but we're not there to put barriers. And as a result, Dr. Martin, who reads each one of the tests, I think gets 550 tests on that he needs to go through every morning.
So because of the way the interface is structured, every test that's done in the COVID clinic generates at least 2 and probably 3 reports that I need to sign. So if we're doing 120 tests a day, I'm signing 400 documents. And the interesting thing is that all of those results are, the negative results and the positive results are being dealt with by our quality people and by the people of public health. So I am getting the strongest right index finger.
Clicking.
Is it still no out-of-pocket expense for anybody that gets a test here?
Yes.
Yes.
And that's true in Cleellum as well. So again, we try to collect everything we can from government programs and from insurance companies, but we don't want people to pay anything out of pocket.
Are we seeing any influenza?
I heard one case. And if you look at the current CDC influenza map, it is something I have never in my career seen in December. There is one state that is yellow and the rest of the map is green.
Yeah.
It turns out that this stuff we're doing actually does cut down on the transmission of viral illnesses. It's interesting, if you go back, you can find pictures from the influenza epidemic in Seattle in 1918 of passengers being refused entry to a trolley because they weren't masked. This isn't new. I mean, most of the stuff we're doing now, we figured out in the bubonic plague.
I saw a picture from the Toronto newspaper of Canada. The guy, there would see people with a mask on. This one had a sign on his chest. It says, "Mask up or go to jail." And it was from the 1918 flu. So I didn't realize that they actually masked up back there during that flu, but we know that's the way of protecting from the virus.
Well, and some cities were quicker to relax those restrictions than others, and the examples that are quoted are Philadelphia and St. Louis. Boy, it's been 30 years since the med school class. One of them maintained restrictions, one of them didn't. One of them killed off a chunk of their population.
Let me just ask a really parochial question here. We were completely virtual with these meetings for a while, and then we went to sort of some people around here. And is this something we should, I mean, should we plan for January to be completely virtual, or should we continue to do this?
So I would like, that, again, that proclamation was long and wordy, and at the very top of it, it said healthcare facilities are exempt from these and may continue in whatever phase they're currently in. That being said, we intend to check in with the board on a month-by-month basis and see where your comfort level is and see where you want to be. We are okay assembling, with people outside of our family in a group this size. We are allowed to do that. It's up to you whether you want to continue to.
Okay. Yeah, we'll just see how things kind of go and how things evolve.
We're going to stay nimble. Same offers made to Hospital District 2 every month as well.
What was it you said earlier? Whatever happens, whatever might happen will be there. I thought that was maybe a new slogan we could use.
Well, it's the gift of 2020. You do what you have to do, and it's been quite a journey. But
I guess the tagline that we've been using with staff, and I think it's true, is we've got presentation tonight is hopefully gives you guys comfort in preparations that we've made. But bottom line, we ain't going.
But it would be easier to get this if people didn't get together at big parties.
Good.
Can we add that to the
Tagline. Put notes to a tagline.
I mean, the scale is, though, it is very, we're talking 100-year virus, right? This is unprecedented. The fact that we're able to kind of try to get in front of it by just doing some basic things.
Well, it's interesting because in medical school, the reason we studied the Spanish influenza pandemic was not to ask why it happened. The question 30 years ago was, why hasn't it happened since? When will it happen again? Because it will. And what will it be? And so the amazing thing is that we went 100 years without it. Influenza pandemics prior to 1918 were fairly frequent and typically on the order of every 7 to 10 years. But because there wasn't widespread travel, they were contained. It wasn't until air travel that you really had the potential for a global pandemic.
Thank you.
Yeah, thank you.
Appreciate it.
Thank you. Any other comments from the board? Okay. Appreciate presenters on Zoom with us. Mandy Olson, quality.
All right, so you do have my report, but there's a few things I would like to go over or ask about the last QI Council. So one, in my report, I did talk a little bit about COVID, and that was before we had this presentation created. So I think that's all a repeat if you look at that. But then our QAPI, our Quality Assessment Performance Improvement Plan, that we are required to have every year for CMS guidelines and the Department of Health. We had a policy that we reviewed. We have a QAPI policy that came forward to QI Council, and QI Council approved it, but I do ask that the board review it. So it doesn't need your approval necessarily, but the board is responsible overall for the quality of the organization. And so I would be prudent to have you be aware of that policy and make sure you can take a peek at that.
Well, Mandy, just let me say one thing really quickly, if that's all right. Yeah, so Terry and I were in the QI Council when we reviewed the QAPI plan. I emailed you guys this late last night. So just our next meeting is on the 14th of December, QI Council. And we'll, QI Council will review and approve this plan. So if you wouldn't mind just looking it over, if you have any comments or suggestions to change it, just send it to Mandy or to me. And we'll put that in, but please just before the 14th, because we're going to approve that at QI Council.
Do you prioritize those various bullet points? I mean, so I read through it, but I wasn't clear, is some more important to you, to the organization than others? And if so, how is that indicated?
Do you mean within a department, or you mean?
Both, global and within the department.
I think the idea is that the different departments, those are their priorities, right? So that I don't think we prioritize a department over another. It's within the department. As for prioritizing within a department, I think the plan is to do all that stuff. Now, if they couldn't do all of it, they'd have to prioritize. But right now, I think that's the idea, is that they're going to do all of it. So it's
Yes.
So I think that they only have to prioritize it if they couldn't do it all. But Mandy, did you want to address that?
Yeah, I'd just like to say something. I mean, the intent is that when our directors are drafting this and meeting with their senior leaders, part of what we're trying to prioritize is strategy and the values that the organization has. So you'll see there's those columns that have those check boxes with either strategic initiatives or our values. And although it's alphabetized by department, there is a hierarchy in a sense in that Julie does have a QAPI plan that is from at the administrative level. And I would say that is, that everything kind of falls under that or should align with it all the way up to the board strategies. Does that make sense?
Yeah. Mandy, you changed this a couple of years ago, or maybe it was last year on the QAPI plan, where you have that column as to how everything fits in with the strategic plan values. And so that's what you're talking about, really, is how it all sort of follows from that, right?
And to be honest, in the past, first of all, it was not required that every department had a QAPI plan. It used to be that it was really only clinical areas that had to have quality improvement, but CMS changed those conditions of participation and said that every department, even non-clinical areas, had to have it. And the other thing was, when I very first started, a lot of it was based on initiatives out of Quality Improvement Council, or that I had kind of direct oversight of. And it wasn't as collaborative. We didn't look at scope of services, which we need to do every year as part of our conditions of participation. So it changed a lot. At Julie's suggestion, why aren't we doing this work together, aligning, having the board input? It used to honestly be a report and a suggestion from me to the board, and they approved it and we went from there. So it's very much more collaborative and engaging the board at this point. And so what happens is QI Council recommends its approval to the board, but ultimately the board does approve our QAPI plan for next year or not. And part of the feedback I think we're looking for is, we really wanted to align with strategic initiatives, but especially as you saw, with these stretched resources in a pandemic, we really do want feedback, especially if it helps us narrow or sharpen our focus on strategic plans or priorities. So, to your question, John, I think that's something to think about. Does this seem like a wish list thing to do, but doesn't necessarily align with what's going on? And we need to say, gosh, that looks like too much.
So I think quality meets again in December. The idea is the board would get any additional input to Matt, and then quality will bring the QAPI plan forward for approval on the January 7th meeting. Is that right, Mandy?
Exactly.
And Matt, you had as soon as possible for feedback. What is really the drop dead when it's no longer
14th?
14th?
Yeah, on the 14th, because that's when QI Council meets. I mean, obviously, if you can get it before that, so Mandy can incorporate it into the document for our meeting on the 14th.
I interpreted it as you wanted it by tonight's meeting.
No.
So it kept me up late last night.
Yeah, but no, it's good reading.
I mean, I looked at it, I felt like it was fairly complete, fairly aggressive considering, you know, COVID, but I think you can see a lot of energy and effort went into that plan. And I appreciate that kind of effort, especially considering everything else is going on. So thank you.
I'll just mention, I guess, too, one of the things that happened at QI Council prior to reviewing these drafts is I forced all of our leaders to give me what they had accomplished in 2020. So that reflection prior to looking to 2021 and saying, you know, we have these great plans for 2020, what were we able to get done? Or even if it wasn't something that was on our QAPI, what quality work have we accomplished related to COVID? And that was just incredible to me to see all that we have accomplished that isn't even related to COVID this year. And I don't know, it's very inspiring, very proud of everyone and all their work.
Terry, did you have anything to add from the QI Council and reviewing the QAPI?
No, I you know, it is like what Bob is saying, it is a very aggressive plan. You know, these are initiatives that each department in the organization sees that they need to upgrade their department, upgrade the quality in their department. And I want to thank all the department directors, managers, and everybody that adds to that quality plan, because by doing that at each level, that just increases the whole quality of the organization.
And I will just say my role in this largely is to take the 14 huge initiatives that Carrie Barr and her managers want to do all at one time and pair them back to something we think she can do while running 7 or 8 clinics. So.
And adding new ones.
And adding new clinics.
Yeah. Great. Anything else, Mandy?
I just, nothing more about QAPI. I do have the dashboard and metrics attached in my summary on the dashboard. I'd be happy to take questions about that.
Any other questions?
And Mandy, we're also gonna review at the QI Council about what to include on the dashboard, right?
That's correct. Yes. And so that will come forward next board meeting also. Here's our revisions to the dashboard that you would receive each month. And do you approve that or not?
Right, so that's another thing. If anybody has feedback on what's included on the dashboard, if people have other things. We did change it at the end of last year and took some stuff out and added some new stuff. And so this is something that is flexible. So if there's some information that you need that you're not getting on the dashboard, or if there's something that you think you don't need on here, talk to Mandy and she can bring it to the QI Council.
Absolutely, that's perfect.
Great. CEO report, Julie.
Yeah, I'm happy to answer any questions. The only update that I have to my report is that we did meet with Hospital District 2 commissioners, and the decision was made to delay the ambulance station 99 project until April sometime. So that new facility, you'll be invited to a ribbon cutting probably in September or October instead of June or July. So other than that, I'm happy to answer questions.
That may be a mask cutting, sir.
Yeah.
I like your story about the DNV.
Wasn't that something?
Just stellar to be ready to go despite not expecting them and thinking that they had gotten the message to delay.
Well, I'll tell you, it was amazing because we met Mandy and Julie, you know. So we did just take a couple deep breaths and said, you know what? We're ready. Yeah, let's do it. And it was DNP who backed out. So it is a great story and a reflection on just how ready your senior leadership and clinician team feels. So
it says that we're shooting for next year for accreditation. Does that mean that we don't expect them? Well, it's late in the year anyhow, but it's going to be a while before we expect them back?
That's correct.
Thanks a lot for sending that interview reflection.
Yeah, absolutely.
Yeah, anything else, Julie?
No, I've asked Amanda Scott to update you on her customer service staff engagement. And I pointed out in my report that this was Amanda's last meeting. Somebody named Lizzie Ann is going to be interfering with her ability to come to work. So, Amanda?
That's right. Thank you. So we just want to give the board an update. When you think back to earlier in the year, we presented a staff development plan. And as Mandy mentioned, I was really happy going through our QAPI goals. And I won't go into detail because I do have some of that listed in our 2020 QAPI and throughout our board reports throughout 2020 that I've been providing. But we've been able to really focus on staff development still, even with COVID. Some of our main priorities were workplace violence, which we talked quite a bit about last meeting and partnering with our Evade partner, and also customer service training. That was a big focus this year. It took a lot of research and discussion. We did staff focus groups. We had a planning committee. And so I'm very happy to share kind of an update on that. And I did provide an executive summary with more detail on page 34 to 35. But really just kind of to recap where we're at today with that. The purpose of the training, which is complete now, we partnered with a group called Idea Learning Group out of Portland, who's really their specialty is creating trainings for organizations based on their values, their culture, their data. And they have completed that draft, and we have a 2-hour workshop built that's built in virtual format, just because that's how the world is right now. But we do have it as a flexible model where we can present it live someday if we choose to as well. And the 2-hour virtual workshop, again, the concepts really, the focus is communication, perspective shifting, empathy with our patients, the KVH values, what expectations and what do we know about KVH already in terms of customer service? So really kind of reflecting on that. And as a starting point for further conversations, we know that cultural change and behavior change take more than one-time training, of course, but it's a way to really bring people together on this topic and reflect on it. And it's not intended to be a scripting or an academic approach necessarily to customer service, just one method of really starting the foundation. And from there, we really plan to engage our leaders with leadership development on this topic. We did do that a little bit this year. We did a coaching for customer service workshop for our leaders to kind of prime this up a little bit. And so we're going to be engaging our leaders on how can we really continue the conversation with the teams, doing team-based conversations, little micro-learning lessons to keep the conversation going, and really focusing on all the differences that may take place in an organization, but what are the core that all of us commit to when it comes to customer service. So for this month, we have already trained our potential facilitator list. We have a trial session that we're also going to be inviting our PFAC committee to for later on in December. And then we plan to roll out in 2021 kind of a flexible blended approach, working with our directors on some open workshop styles for people across the organization, but also some team-based learning for people to really dive into their roles and responsibilities if that's the preferred method. So it's been a fun project and we really appreciate, we've had some staff participation. It's a flexible model that we can adapt to, and if we have to push it back a little bit because of COVID, then that's okay. But we do want to continue progressing towards our goals in this area and are excited to continue the conversations. So any questions on that topic?
Question?
I think it's exciting to be pursuing this and everything, so kudos.
Yeah, I think it'll be a great topic. I think kind of going back to well-being and just connection, I think it'll be a great timing for it, actually, of really centering us on why we're here. And as Julie mentioned, this is my last board meeting, probably until either late March or April. And so I've really enjoyed my first year here at KVH. If you do have any questions or needs in the meantime, you're welcome to reach out to Julie or any other senior leader or connect with the HR team directly, and they'd be happy to answer any questions for you. So happy holidays and happy 2021. I'll see you in the spring.
Best wishes to you, Amanda.
Thanks, Amanda.
Thank you.
You will
Thank you very much.
continue to get HR reports on a monthly basis. They have a good plan to keep HR going in her absence. And we were talking today, I expect we'll be getting a lot of 2 a.m. emails from Amanda as things get find out how she, but her team Mandy Olson's going to huddle with them. I'm going to be down there, but she has a very strong team ready to go. So.
Great, thank you. Amanda, Julie, resolution?
Yep, please. Resolution 2008, it concerns the acquisition of real property. Have a sheet of paper that has the basic terms for the acquisition. And on the back of that, just as a reminder, is the valuation. So the terms, this is for 107 East Mountain View and the residents at 709 South Pine. We settled on $2.875 million, of which we've already put down $50,000 in earnest money. Closing date will be on or about 12/31/2020, and we will take possession at closing, with the exception of some space that we will be leasing back to the current occupant. That's about the roughly 10,000 square feet. Dr. Haney will be leasing back about 3,500 square feet of that building, and that lease continues until 12/31/21. And anytime during the next year, he has reserved the right to cancel the lease with 30 days notice. So there will be no apparent, so his practice will continue as it is. He has full parking access for his patients and his staff. His signage will continue as it is. I think what we're probably in the balance of that first floor, at least, we're going to be looking at establishing with Dr. Hibbs coming on and some of the clinic support that we have, putting clinic administration in a portion of that building. Other than that, it will be a very quiet time. Also at 709 Pine, which is the residence that is currently occupied and leased, and as part of the closing at the end of 2020, Dr. Haney is responsible for making sure those leases are terminated. So I'm asking for approval of the resolution. The purchase and sale agreement has been executed. The resolution 2008 will approve that purchase.
I move that we approve resolution 2008 as written.
A second.
Motion by Erica, second by John. Any discussion?
You said the Dr. Haney have the tenants move out by this December, 4 weeks from now, or a year from now?
This year.
This year.
Yeah.
All in favor?
Aye.
No opposed? Great, thank you.
Take a moment.
No.
It seems like there ought to be music or something.
Yeah, there was a lot of work with that. Great job.
And that's it. I have nothing else.
Again, yes, good job voting.
Oh, I'm sorry, I was incorrect. At your place, you should have a temperature and symptoms tracking form. It's,
yes.
As employees of the district, you're required anytime you're in the building to fill that out.
Not just that this is
No, this is for you guys to produce, and then you just do it across. It's 28 days long. Make sure anytime you're in the building, you fill it out, indicate that you don't have any symptoms when it's full.
Turn it into
me.
To you.
Yep.
Good job, Julie.
Hey.
Great infection preventionist. You didn't know it.
I was having a little problem hearing you through math. You want us to fill this out right now?
For tonight's meeting, yes. So every date, you put the date at the top, and indicate your symptoms.
If anybody hasn't taken their temperature today.
When it's completely full, you can turn it in to me.
Oh, okay.
So when we turn it into you and there's a bunch of Y's circled on it, are you gonna, if there's a Y?
I think you're instructed at the bottom if there's a Y, what to do, and it's not continue about your daily duties.
Okay, very good.
All right, Dr. O'Brien. Chief of Staff.
I saw it said Timothy left the meeting. I wonder if he got.
No, bottom left.
But he also has a phone number.
Might be muted.
your response. Dr. Bryan?
If you're using your phone, dial *6.
Do you want to go to the medical officer when you come back, Dr. Bryan, or?
Sure. You have my report. I've given our half-hour presentation, went an hour and a half. I'll call out, Julie alluded that Dr. Hibbs will be our first medical director for clinic operations, and in my report I've outlined the importance of that role. I think he's an excellent fit. When we first created that role, we interviewed a candidate. Dr. Hibbs was on the interview team, and by the end of the interview, it was readily apparent to all that Dr. Hibbs was more qualified than the applicant we were interviewing. So I'm delighted to have him in that role. We've started interviewing for medical director for hospital services. We had our first candidate today. And we have another interview next week, and we hope to move quickly.
This is for, to manage the hospital.
Correct. The role that Dr. Hibbs is in currently. I would point out that my fears of 1024 were overstated. We were at 1,000 cases. I thought we might be at 1,500 by now. We're only halfway there, so I'm pleased by that. And then lastly, as we were discussing the role of MD clinic operations with Dr. Hibbs, it became apparent that he was looking, and justifiably so, looking at that as a half-time position, which forced me to realize that I was trying to do that work in a fragment of a 0.5. And since the beginning of COVID, I've probably canceled more clinics than I've attended. It hasn't been fair to my patients or to our staff. And so the reality is, in 2020, CMO of a small but growing organization is probably not a half-time job. So I'll be stepping away from family medicine Ellensburg and continuing with home health and hospice, but devoting more time to administration. And I'll take any questions.
Yeah. Any questions? Dr. O'Brien.
Yeah, now can you hear me?
Okay.
Yeah, I was muted and I couldn't figure out how to unmute, so I guess I solved that. Anyway, the MEC reviewed the applications and requests of the list of providers that you have. There's 9 initial provisional appointments, and 3 of which will be working here, but 6 are remote providers. I'll just go through that list. Of course, it's a 1-year provisional appointment. It's Daniel Spiger will be working here as a hospitalist, and Lauren Wickholm, woman general surgeon, will be joining us. David Ishimitsu is a teleradiologist. Sheila Linham is going to be a pathologist with insight for us. And there's Kelvin Ma, VM telestroke provider. There's Rachel Monick, who will be per diem working in our emergency department, although not based here. So she is designated as an associate appointment. Fatima Milfred, VM telestroke. Viren Patel, VM telestroke. And Martin Price, ONRAD teleradiologist. Those 9, we reviewed their records and found no serious problems, and recommend that the board approve their 1-year initial appointment as listed. Then there's 4 reappointments: Tom Merrick, orthopedist; Rob Waganek, CHCW, family medicine; Stephen O'Donnell, VM telestroke; and Ari Plasker, ONRAD teleradiologist. So we recommend that the board approve these applications and privilege requests.
Any questions for the board? Can we get an approval?
Move to approve.
John approves listed.
Second.
All in favor? Aye. No opposed? Thank you, Dr. O'Brien.
Thank you.
Okay, thank you. Yep, I have nothing else.
Scott, CFO.
Thank you. You've got the October financial report. A very strong month with revenue. We exceeded our budget by $1.7 million, and we're closing that year-to-date gap on revenue. Revenue is across the board was positive in nearly every part of the hospital. I think the real focus this month is on the expenses, and there were some unusual things related to expenses. We had significant expense variances, and I'm
They're all your fault.
primary reason for those expense variances. We, in working with doing some planning and trying to anticipate how to manage some of this CARES revenue that we have, we worked with our auditors and made the decision to expense about $590,000 of expenses related to the Medical Arts Center building that have less than a value of $5,000 and below our capitalization threshold. And so the supply variance of $700,000 is primarily related to that. And that entry caused the clinics to look awful. And so I've apologized to Carrie more than once already, but I will do so once again, that if you back out $590,000 from that clinic number, you saw that the overall performance of the clinics was very, very good. So the other, we've also accelerated some of the repairs and maintenance work that is going on around the hospital. It is occurring up at Radio Hill. It is also occurring at the district houses that we have. And so a good part of that purchase service variance of $386,000 relates to that. I think the number was $161,000. And then some of the other purchase services relates to a lab testing and testing for COVID and some of the additional lab services. So we had a negative expense variance of $1.1 million, but with the positive revenue, we were able to post an operating gain of $267,000. And year to date, we are at a positive variances of almost $1.1 million. You also see in the year-to-date expenses that we have a negative expense variance. We're on track to exceed what is authorized by our 2020 budget that you all approved last year. We're on track to exceed what was authorized. And so there is a resolution 20-09 that is essentially requesting permission to exceed what our authorized expenses will be. We do expect, as we try to, we're looking for other expenses to book in 2020. And so it's intentional that we are trying to do this, and that resolution addresses that. We talked about it at the Finance Committee meeting. John, do you have any?
I'm just going to say, just to make it clear what the strategy is, the way the COVID money, the rules of it are, we can't make a larger profit this year than last year. It would go against the COVID money, so it benefits us to play by the rules to bring up any expenses we can, future expenses, and book them against this year from an accounting standpoint to play by the rules and maximize potential COVID benefits. So that's why we felt this was a very useful strategy, but it needs the resolution to make it legal and so forth, to make sure Scott has the budget to work with to pay off these debts.
Okay. Then it was just a good month all in all, despite some of the variances related to payer mix continue to be very, very good. Our days in AR went up a little bit by 4 days. It was all the revenue that we had what was driving that up. Our days cash on hand continue to improve, and so we have plenty of money to purchase the building. That we'll do that. It'll use about 12 to 13 days of our cash that we have to purchase that.
Good. You're going to have to make this graph bigger.
Julie's goal was to make sure we didn't have to change this graph, so we'll be able to accomplish that. But all in all, a very very solid month for the organization, and I'm going to a bit of a prelude to the coming months. November is also a strong revenue month. We'll probably exceed budget by close to $2 million in revenue. The preliminary numbers, we already can see it. We will likely, last year, our operating margin was about $2.9 million. That is our goal once again this year. And so we will likely be backing out some of the CARES money that we have recognized up in other operating revenue. So you may see some of that other operating revenue flip back out. But the rules of the game are that me and nobody I was on a CFO meeting with all their rural CFOs today. Nobody has a clue what to recognize, and with this CARES money, we're just struggling. And we talked about anxiety related to CARES and everything else, or COVID. CARES is creating anxiety and stress among CFOs.
On what direction the feds are going to take, or
Nope.
Rumors?
I think the good news is the auditing firm with DZA audits the majority of public district hospitals like ours. So the conversations that Scott's having about how am I supposed to manage this, what can I apply, that DZA is having with all of their clients. So every hospital in the country is having this conversation right now. So.
We're fortunate to be, not all hospitals are performing positive margins like we are. We're in a fortunate position, really. We truly are, and so we don't know what that ending number is going to be, but we'll work closely to. We've got a strong balance sheet, and we're looking quite good.
I would just call out the last 3 months have been strong months, but we're still almost $6 million behind because we essentially closed for 2.5 months at the beginning of the year. So a lot of this is pent-up demand that we're seeing here in the hospital and as well as in.
And as in that hour presentation earlier, you see how tenuous this is also. It could change with a spike in inpatient COVID patients. We may have to shut down elective surgeries. It would be our choice to do so, but we may have to do that to make sure we can care for patients. And so, truly, it really is day to day, clinically, financially too. So, if there's any questions related to the August or October financials. There's a couple of items for capital that
we need 2009 approved.
Yes. Excuse me.
Just because, go to the auditors meeting every year. Do we need to add that to the agenda? I know it'll be on the minutes, but do we need to add the 2009?
I think we're on.
Doesn't matter.
So let's go ahead and get that done. So we do need a motion to accept resolution 2009. This is, a resolution amending the budget for Kittitas County Public Hospital. We have a motion.
I would move to accept the resolution 2009.
Motion by John, second by Terry. All in favor?
Aye.
Thank you very much. The other handout that I left for you was a copy of the proposed 2021 budget. And this will not be approved tonight. It will be approved at the January 7th meeting. But it lays out the assumptions that we may use to come up with the budget. And I guess we can have a more detailed discussion about in a month from now if you have questions. But feel free to, if you see any issues that have concerns, please email myself and we will be prepared to address them. I think that John and Terry would like to dig in to the budget, and so Jason and I will meet with them either via Zoom or in person sometime in December to go through and address some of the questions. And maybe as we address their questions, it may in turn address any questions that you may have. But this was just a more FYI information for you to take home this evening and review at your leisure, and then come up with some questions. I can go into a little more detail if you'd like, or
so we'll vote on this on the first January meeting.
Yes.
At what point will the other commissioners get a copy of kind of the finalized document for the budget?
Hopefully this is the finalized document. Okay. We hope this is the finalized document. If there's, but you can see that there's significant revenue growth in the document. We continue to be adding providers and growing as we serve the community. So there's significant revenue growth. We're adding about 34 additional FTEs. All but one of those 34 are in clinical areas or clinical support areas that, and we have one in the administrative area. But for the most part, it's.
So if you look at the last page, that's budget. So we still have some blanks. That's why I'm asking if this is the final call 2021 budget. For example, row 17, 19, 21, et cetera, don't have anything in it yet. Will the commissioners see that prior to voting for it on January 7th, or is it not relevant?
Row 17, we'll fill in those. Thank you.
I guess I'm just circling back to my question. I want them to have a chance to see all the numbers, not just a minute before they have to vote on it, but when would we give them a document that reflects the final filling in of this information so they have a chance to peruse it as needed?
It will go out with the budget packet. Or, excuse me,
the typical board packet will have the final version. Yep. Okay, terrific. I just wanted to understand that.
This is a near final.
Yeah.
That's why it's a near final draft. So that's, so you'll have really hopefully a month to come up with any questions that you might have about what we've done. And
if anything drastic was to change relevant to potential revenue because of COVID, would this document change at all, or this is the direction we're going? We'll sign off on January 7th and make any adjustments after that. Is that?
I would say this budget would likely not change, but if we had to make mid-course corrections during the year, we would do so. But Is that, Julie, is that fair?
Yeah, we had that conversation this year, you know, do we focus on budget or do we focus on actuals? Because obviously the budget it's
a moving target.
This is our best, and in fact, we had a lot of back and forth about, do we look at actual 2020 or was our best thinking about normal operations budget 2020? And this is because we typically go in with an annualized current year, and that's our basis for projection. That obviously didn't feel like the right thing to do this year. So I would not propose that we do something that looks like an adjusted budget unless something truly dramatic happens and continues. So.
Thank you. And
capital expenditures?
Capital expenditures. John, do you want me to talk about them?
So we had a discussion about these two very similar expenditures. Cepheid 16 bay. This last June, we approved a 4 bay, which we still have not received, and we've outgrown that. And so the idea is take the money we allocated towards that, which is around
about $76,000,
and just upgrade now to a 16 bay, which has, you know, the same uses as a 4 bay, but can work 4 times as fast. And the new cost is $225. So actually, we're approving $225 minus $76 for the differential, because we no longer will pursue that 4 bay and essentially have that money freed up. And then the biofire, the same sort of thing. It's just a lot of it's related to COVID, but it does have uses. Things are slowing up in the ER because they're waiting for tests to get done before they can move forward. And so we had a good lengthy discussion about these two items. They have the purpose for COVID, and they also serve the purpose for a lot of other tests. And there was no disagreement that we need it. We're backlogged, and we'd save a lot of money by not having to send out to the external labs. So a lot of the billing would stay in-house that way also. So we felt that it was a good value and a good investment. And we approved it at the financial committee meeting on Tuesday. Scott, anything on this?
Nope.
Does 16 bay, does that push back the delivery time for that?
It does not.
So we'll get
it might actually accelerate it a little.
Still sometimes.
This delivery is still the biofire. When we will be able to get the biofire, they have them available. And you know, they've got reagents. We have a biofire currently, and so this is we've had it's a 2 bay machine, and we've had a bay go down, and like it says, it's delayed testing. And so with the additional COVID patients that are coming in the emergency department, we, in order to accept or admit the patient, we need to know whether or not they're positive, and in order to transfer them, the receiving hospitals need to know whether or not the patient is positive. And so this will allow us to test all the patients we have.
And the other thing I would point out with both of these is that they aren't just COVID tests. Particular long ago and far away, the primary use of the biofire was GI testing. It's our quickest way of getting C. diff results.
How much, I seem to recall that the biofire, our cost each time we run, say, a COVID test is hundreds?
Hundreds.
And we expect the Cepheid to be much less?
Yes, the Cepheid is just with, I don't know exactly what the reagents will be, but significantly less, probably cents or $1 per reagent test.
I would, and this is just throwing something at the wall, but I would guess it's probably tens of, but the biofire, because of everything that it does, every time you run it, you're essentially running 22 tests.
Gotcha. And when you compare their accuracy, is one superior to the other?
I don't know the sensitivity and specificity on the Cepheid. except to say that the pathologists that I've heard talk about it as a highly reliable test, as opposed to Binax. BioFire, their technology is very slick, and they're looking at 97, 98 sensitivity and specificity for each of 22 tests on the panel.
Any further discussion? So we have 2 capital expenditures. First one is Cepheid Gen Expert 16-bay molecular instrument. Can I have a motion?
I'll move to approve.
A motion by Erica to approve.
I'll second.
Second by John. All in favor?
Aye.
Aye. All opposed? Second capital expenditures, BioFire instrument, 2 additional bays. Have a motion. That's capital expense. Motion by Erica, second by John.
I'll second.
All in favor?
Aye.
Yeah.
Thank you so much.
Yeah, operation. Vicki?
Hi again. My report is on page 52 to 53. And so I don't have anything to add currently to that. So if you have any questions, I'll be happy to answer or clarify anything.
I was curious about the weekly gross cafe revenue. Since that's not open to the public,
right?
How can we?
Yeah, we didn't really expect any movement on that since, you know, we kind of shut down. Jen's been struggling and trying just to maintain and serve our staff and our patients. So we really didn't think we were going to meet target there.
Well, I've been doing my part.
Yeah, me too. Yeah.
So as a commissioner, if I'm here at the hospital at some meeting, am I considered a public if I wander in to have lunch there?
Nope, you're an employee.
No, yeah.
All right, then I may do my part some too.
Yeah.
Vicki?
Yes.
This is Erica. Can you take a stab at pronouncing the name of the monoclonal antibody?
No. Can someone else? Yeah, it's just kind of like it's.
Come on, Dr. M, you can take that one.
Yeah.
I tried to get Manda to name her baby this.
Ravimab, excuse me. And personally, I think it should have been Shabamlam.
So I can't say I've been hearing this because then I would know how to pronounce it, but I've been seeing this name in a lot of publications and a lot of news. How excited should we be about this? Okay.
Marginal effect size. It's a 1-hour infusion, only appropriate for the outpatient setting. Has had a small impact on hospitalization rates. No idea what final cost will be. The beds bought some and they're sending it to everybody. We aren't sure how to use it.
So it's only appropriate in the outpatient setting because when hospitalization is required, it's not very effective?
Exactly.
Okay.
The original studies had an arm that was going to look at benefits during in moderate and severe disease, and they stopped the arm for ethical reasons.
Great. Any other questions?
I would just, not about Vicki's report, but if there's, I'd have one additional things I would like to add of finance related.
Vicki, anything else?
No, unless there's any further questions, that's all I have.
Thank you for your report. Yes, Scott?
Excuse me, a piece of good news and some other news not so good, but I have a copy of a check here that we received from the foundation for $260,796, and this was donated by the foundation for the surgery towers that we had. So they have So that was a piece of good news, and we're really grateful to get that. The other not so good news is you may be hearing problems from community residents about the radiology bills that they're getting. There's the radiology company called PCO Radiology that does the professional fee portion of the radiology, had some challenges getting the data off of our system. And so, for instance, Mandy received a bill, and there were 3 pro-fee readings. 2 of them were billed appropriately to her insurance company, and then 1 indicated that she didn't have insurance at all, and so she was left with the whole balance. And other patients are getting that bill also. So we are working with the company to try to make sure that interface issue, the data that we have in our system is as good as it gets. But for whatever reason, it did not cross over, but it's causing some anxiety with patients, and we're getting the brunt of the phone calls that are coming in to us, and they're all patients are sometimes question whether or not it's fraudulent also, because it's out of Dallas, Texas, and they're saying I had my services in Ellensburg. Why am I getting a bill from Dallas, Texas? So anyway, just FYI, that's out there.
On that same note, it's interesting you bring this up because for the past couple months I've been getting a text from somebody I did not recognize.
That's probably them.
Why is this has got to be a scam. I'm not going to answer this and give them my financial data. Lo and behold, a few days ago I get an actual paper bill in the mail for a legitimate charge, and I thought, maybe start off with the legitimate looking bill instead of a text. So I don't know, is that becoming customary to bill people by text message?
They do it. We have, I received a call from someone up our county who has only a landline, and they were sending a text message to a landline, which doesn't work at all. And so we've told them they need to be sending out statements. And so anyway, there's a number of different problems, but maybe we're getting some negative blowback because of this.
How do we assure that those who might be just paying it are going to get their money back? Right. So if they're just like, oh, it's healthcare, I'll pay it, and then.
Well, given the number of phone calls that we're getting, people aren't just paying it; they're questioning it. And so there's a lot of calls. I doubt that their people are just paying it. They're questioning what's going on with it.
So how is it being resolved? So a call comes in, somebody's very upset, Mandy's upset, she calls in. What are we telling them?
One thing that we're trying to address the call and tell them it's what the bill is for, and we're also taking that patient's name and phone number. Part of the problem that the patients are experiencing is they call and they can't get through. They're 2 or 3 hour waits and then they're dropped. And
you're calling this
organization, and so we're taking those patients' name and date of service and their phone number, and we're sending it to the company and said, this is your issue. You need to call these patients back. They've tried to reach you and they can't get through. Call them and help them address this. So are
these correct bills? Are these real bills? Or are these mistakes?
Actually, both. The bills are real, but in the case of Mandy, they did not bill for one of the studies for insurance companies. So that was incorrect.
Correctly.
Yep.
Is that? And have you resolved it yet?
They said that they would rebill.
They being this entity, but this entity is working on our behalf, are they not? I mean, you didn't go to this entity.
Not directly.
Huh?
They're independent providers.
So it's not imaging here.
It is imaging. There's two pieces to the imaging.
The radiology.
There's the technical part that we bill for, and this is the professional part that the radiologist bills for. It's the professional portion of that radiology.
But if a patient comes here, aren't we being KVH responsible for getting this sorted out for them? Why are individual patients having to solve this problem?
I think that's what you you're saying that we're now putting it back on.
But what I heard is you're sending a list of patients to this group saying you call these people and make them happy, even though our.
No, you call these patients have an issue, you call them and get it resolved. We can't, I cannot resolve it. It's not, but we can facilitate.
I guess I'm still missing something. They come to this facility and they're getting a charge from a third party that's making a mistake. We don't have the authority to step in and say, this is unacceptable, you can't treat our patients this way. So if we were to have an orthopedic surgeon who didn't employ, do a case in our operating room.
He or she's just renting space basically, or?
Not even.
Okay.
They bill for their services in the operating room. We bill for the insurance.
The physical space.
Correct. So if in an office that we don't employ, they screw up the billing, it looks bad for us, and it behooves us to help facilitate a resolution, but we're pretty powerless.
That's what privileging non-employed providers on your medical staff, and it used to be very few employed providers, so everyone got a KVH bill and a third-party bill. So
and a Valley Clinic bill because Dr. Larson came over and saw you when you were in the hospital.
So we can call them and make them aware, and you're right. It's kind of transparent. If somebody comes in labor and a CHCW doctor delivers the baby, they call our billing office and say, fix it. And that's what they're trying to facilitate. But they cannot physically get into that billing system and make it right.
But what we are doing is we're making sure they have the correct information to bill.
But there's no other method to enforce that they address this in a timely fashion and talk people off the wall, or?
Well,
in other words, can we exclude them from being part of our facility in the future? I mean, is that even an effective method of encouraging them to fix this? Like, fine, then you cannot be a radiologist for our facility in the future. I don't know. Maybe I'm not understanding how this whole system works.
I think the lever here is this company's not getting paid.
Yeah.
And this is not the only third party. We have, Insight Pathology, our anesthesia providers bill for all their own services. Until just a couple of years ago, our ED providers did all their own billing. And when their bills are screwed up, they're not getting paid. Just like if we've got something wrong, it doesn't get paid.
So it's an emotional stress on the patient to start, but not a financial, unless they, like Bob said, just wrote a check because it's a healthcare bill and they got to pay it. But and then they get people's numbers because they have access to that since they're billing. In other words, how do they get private phone numbers?
They get the demographics for the patient off of our system. We have an obligation, and that's where some of the problem occurred. Sometimes the data crossed perfectly, and in 2 of the 3 cases with Mandy, it worked perfect. She was able to bill it, and it was resolved. In the other instance, it didn't cross over, and it was the exact same information it should have, and it didn't, and so.
Is that crossover hiccup, is that a problem on our end, or is that a problem with theirs?
It's on their end. It's the data. It's on their end.
Corrupting over there.
Or they're pulling the wrong fields or something, but the data on our side was correct.
Did your site
no doubt of being blank?
I was going to say, I mean, it reflects horribly on us, even though we're not in control of it. It's just really frustrating.
So we spend a lot of time, and that's the same is true when insurance companies don't process claims properly.
Yeah.
We're the ones that answer the phone, so we get yelled at. But again, we're the community provider, so we do everything we can to smooth. But Scott's team has no ability to get into that billing system and fix the bill. They can't do that in a third party in a O&W or Dr. Hershey's. We can't correct bills that way.
Anyway, I don't know if you.
All the blame, but no ability to fix it.
That's it.
So, and it's not money that they owe us anyways. Yeah.
Okay. Anyway, that's.
Thank you.
I just wanted to make you aware of that, and.
Can we follow up on that next month?
I'd be happy to.
Yeah. We're approached by somebody who expresses this frustration. Do we
give him Scott's number?
Yep, Scott's cell phone number.
Me or revenue cycle.
Okay.
they seem to already have the number already.
Phones are hopping.
So, yeah, Chief Ancillary Officer Rhonda?
You know, I don't think I have anything else to add to my report, other than I would share that I've been copied on some of the emails going back and forth on the billing problem with PCO, and their CEO is very receptive to resolving this. And I think he's very much working on behalf of our community to get it resolved.
Excellent.
That's good to hear, yeah.
Yeah, any questions for Rhonda?
Just congratulations on the pump implementation. I know that was a big deal, and it seems like everything's going well with that.
Yes, as far as I know, everything's going really smoothly. I know staff development did a great job training all the clinicians, and it was a lot of work for pharmacy as well, building those formularies. Especially right now, we have still people off on paternity leave or maternity leave in the pharmacy, so they were able to accomplish that with a pretty thin staff.
Excellent, excellent.
Thank you, Rhonda. Carrie Barr, Chief Clinic Operations.
Yes, good evening. You have my report and I'll take any questions you might have.
What happened to your expense?
Except for that question. Scott.
Yeah, how's Augmedics working?
Augmedics, it's going really well. We're still in the preliminary stages. We had implemented that in October, and I think we have the majority of our folks on full implementation. And when I say majority of our folks, this is being tested primarily at Family Medicine Ellensburg. It's causing quite a buzz with the rest of the providers and the other clinics that do not have that scribe service, and they have Family Medicine Ellensburg providers presenting at their provider meetings, and everybody's willing to sign up and very excited. But we do provide them a MOU prior to signing on to the scribe service that talks about increasing their templates, and then also making sure that they have timely documentation and that they provide 60-day notice for any PTO. So, but yeah, it seems to be going really well.
I'll just say that it is the first time in my career that charting is transparent and seamless. When I am done seeing patients, I spend some time with the scribe answering any questions, any gaps that need to be filled in. And the next morning, my charts are ready to sign. The closest comparison I can draw is to the days of dictation, where you would come in and somebody would take a tape, and the day after, you would have a bunch of sticky papers that you would initial or stamp, and they would get slapped in the chart. Except that it's easier to do the sign off now than it was then, and nobody has to have a paper cutter to dice them up and put them in the right charts.
And you don't have to spend time after each visit doing dictation, just a few questions for your scribe.
Well, and typically what it looks like in the visit is, especially a patient with a long, complicated history, it's a perfect opportunity to say, so let me recount. And I can basically dictate the history that I want in the chart while talking to the patient. And they can make any corrections, and it's done. I still put the orders in and do any prescriptions. Sometimes there's some conversation about the assessment plan after the visit, but it's light years beyond anything I've seen before. Dragon Medical One came close to this, but this is even more hands-on.
And you typically just use the same scribe?
You're assigned a scribe. Because I've been such limited time, I've had two, one for Monday, one for Wednesday. They've both been excellent. They're both far more meticulous in formatting notes than I ever was in my career, because I didn't have time.
You build up efficiencies as you get to know one another a little bit.
And it is kind of interesting because you do form a relationship with them. You know, one of my scribes was in Sri Lanka and the other was in Bangladesh, and we would compare the weather. They're running on a Galaxy and looking through the camera at the encounter. Most of us have at some point or another taken our scribe to the window so they can see Kittitas Valley. It's kind of cool.
Is the goal to have every provider paired with a scribe that wants to be paired with a scribe?
So documentation is one of the #1 drivers of burnout. And if this can take that driver away, I think it's our obligation to provide it to anybody that wants it. My bias. But we are asking them that, okay, we'll do this, but we expect you to have more production.
So some providers still have in-house scribes that work with them?
Some. So one of the frustrations.
Yeah, we only have about, I think there's 4 scribes that we have that are physically located in the clinics. And that just shows you the actual turnover, the high turnover rate that we do have with scribes. And that's what we're really trying to combat here. And we do have some providers who are not interested in, they weren't interested in having a physical scribe, and they're not interested in the scribe service, and that's fine. And it's not mandatory.
But we are not, no one's losing their job. We're not laying anyone off. This has just been a really high turnover position.
Yeah.
I have a quick question for you, Carrie.
Yes.
How do you make a hire? So this is about the new clinic manager. How do you make a hire for that sort of position? Like, do you do an internal posting just for people who work here? Do you post it externally? How do you do that?
So we did both internal and external. We interviewed both internal and external, and it just so happened that you know, Scott had just the right person in one of his departments that I was, you know, he decided to mess up my books for the month. So I decided I could steal one of his rock star individuals from Patient Financial Services to come work in the clinic.
Among this.
Well, let me just say that I'm glad when it so happens that we can move someone up who's already in the organization into a leadership position. So I'm glad that worked out. So, thank you.
We've had our eye on Jonica for a while. She is a rock.
It's good to be able to develop leaders from within the organization. Thank you.
Carrie,
Yes. Thank you.
question for you on the third available appointment for new patients for both medicine and women's health. Do you know what's driving that increase in days wait for that third available?
So I've only caught part of that. I think somebody was turning a page in there next to the phone. What was something about third available, and that's all I caught.
For new patients for internal medicine and women's health, do you know what's driving the increase in the wait for the third available appointment for new patients?
Yes, so actually both of those were due to just primarily catch up on what we were experiencing with COVID and folks who just did not want to come in. And then now there's sort of this big rush to come back in and get all their services prior to maybe another surge. So it's just really impacting our numbers. But I looked at that twice, particularly internal medicine data. I had to really study that. I thought that was fascinating.
It looks a bit like the COVID curve.
It does, yeah, and that's primarily Dr. Fang that's driving that. It's his services. Everybody else you can get in pretty quickly. It's him that's the outlier.
That's an average of all the providers together when their third available appointment is.
Yes.
Correct. So he's even further out than that, and the others are bringing that number down.
Yes.
Wow. Okay.
Did it have anything to do with losing Dr. Dixon over there? Or?
Okay.
Yeah.
Absolutely, it does. We are still seeing their patients though. And so, and we still have capacity. A lot of the, I know Anita and Andy over at Internal Medicine still have capacity to see his patients. So.
Thank you, Carrie.
You're welcome. Any other questions?
Thanks, Carrie. Anything else? Yeah, appreciate it. Michelle.
Well, hi again. So my report is page 58, and I don't have anything additional to add, but I would be happy to take any questions you have.
I love these graphics, the data for social media, and and then there's a little call out for this dip in sentiment. There's a masking post that was apparently pretty controversial, I imagine.
Yeah, I do expect, so we started our Trusted Voices campaign, and not knowing how many providers we would have volunteering to step up for that, we were scheduling them once a week. And we've actually had a great response to that. And so we're going to be doing them about every 3 days. And I do expect that sentiment to go down. What you see on something like that is you'll get 1 or 2 people that want to engage in a conversation or a dialogue, I guess, between the 2 of them. And it really doesn't have anything to do with what we're seeing. And so KVH stays out of the conversation, but as they express their contrary views, that brings the sentiment report down. But I do, every single time that dips, I go in and I look and I just kind of make sure that, that we're doing what we need to be doing. But I do want to make sure I understand what's happening there.
Is that the metric for the sentiment? Is that based on keywords or reactions that are clicked for a certain post, or how do they determine the sentiment?
I really can't dig into it too much on Archive Social, but what I see, is like it pulls up reports on what are the posts that they think are negative. And so it's generally based on words that are used. And then how it does the background calculation, I don't know. For example, like I got something that was a praise and positivity report yesterday, simply because the person ended the comment with a thanks, but the following 3 sentences were criticizing our willingness to go along with the masking mandate, and so it was a sarcastic thanks at the end. So, the numbers give us some information, but you really have to dig into the comments to see what people are saying. And it is nice because even though there's a long dialogue of a couple people talking to each other negatively, there's a lot more people with supportive messages and just thankful comments. And so we're going to keep giving the message that we need to give and go from there.
Excellent.
Any other questions for me?
Thank you, Michelle.
Thanks, everyone.
Yeah, I'll note in the back of the packet is the Rural Healthcare Leadership Conference in February. So let's see the program schedule in there.
And to sign up for that, do we just? Okay. Yes. Okay. You want that in an email then, please?
Yeah, or you want to go?
Yeah, I'd like to attend. You can put me down for that.
Yeah, this is Carrie. I would like to attend it too.
Thank you. I appreciate that. That's been a good conference in the past. It will continue to be a good conference.
You already have me. Yeah. I'm on board.
Where was this typically held?
Arizona.
No fun.
I know.
Well, I think we could stay at a local hotel and like the spirit of it.
I get that experience.
Yeah.
Go stay in your guest bedroom and see if you can get room service.
So old business, board self-evaluation.
So we've engaged the CEO network, which come in the people of Greg Davidson and Nancy Steiger. So this is something this is definitely in their wheelhouse. They're happy to do it. And the next step, they have tools that they're going to sit down with Bob Davis and John Ward and myself. I think that's Monday. We're going to be on the phone together looking at the questions and the tools that you want to use. Then on January 7th, they will virtually present that tool to the entire board, ask you to complete that tool, and they'll give you a week or so that they can come back and bring the results at the meeting of January 20th.
Great. Any questions from the board on that?
I thought that was a really useful tool when we did it previously, so I'm glad we're doing it again.
And then next steps for strategic refresh?
Yeah, so I talked to Bob about holding off on any additional strategic work until the January 28th meeting. So I feel like we've got an awful lot of stuff going on. I will tell you, the refreshes that we did with the board, the workshops that we did with the board, I think as far as senior leadership is concerned, has really reinforced the movement forward with the strategic initiative of access. We feel like that's really solid. And Dr. Martin has his medical staff development plan. I think the same is true with financial sustainability. I feel like there's some solid work to continue there. And we're kind of pleasantly, in senior leadership, it's kind of pleasantly up in the air about how do we mature those concepts, those strategies of community engagement, partnership, and collaboration. And those have felt squishy as we compared them to what we'd actually accomplished. So, you know, our assessment, I think, coming away from the work, and Mandy talked about the reflection of all the work that has been done, is that there's a new way to frame that strategy, and there's definitely a diversity or inclusiveness component to that. But the other thing that's come out of SLT, and I'd like you guys to think about this as well, in the previous iteration of the strategic plan, we had board sponsors assigned to the strategies, and they worked with a defined number of SLT or leaders in the organization. And as I understand it, Access won. Is that right? Who had the best? Had the best strategy?
Yeah.
Oh, wait a second, Erica, step up for us.
Thank you. Community engagement.
So board.
Got involved with that.
So on a regular cadence, the board sponsor worked with their senior leadership members in order to advance the strategy. We found that very, very helpful. Staff that the board was able to engage with always likes to be able to have the board's ear and the board's attention. So we'd like you to consider using that format again going forward. So I think Bob gave me the grades to wait until January 20th.
But I think we kind of talked about, like, John worked with finance sustainability and Terry on quality, because that was the interest of that. So yeah, we'll just kind of plan on that. Yeah. Okay. Anything else, Julie?
No, sir.
So is there anything else for the board? I just want to again say thanks to senior leadership and the foundation for the check. That is huge. And we definitely acknowledge all the work that's happening, almost like the double work effort happening with COVID and trying to keep things moving. It's much appreciated. So we do have executive session. So, right, do you have?
Yeah, we have a real estate discussion and a risk discussion, okay, and then a personnel discussion.
Okay, great.
So I have asked Linda Navarre and Amanda Scott to stay on. The first item that I have, the real estate discussion, I can knock out in about 5 minutes. Linda, I don't know how much time she will. She's just calling us. Okay, she's just on. I would say maybe 20 minutes. I think she's had a chance to introduce the 2 new commissioners to sort of the outstanding risk issues. And then my evaluation is the last piece of it.
Yeah.
Yes. So very short.
Great. So we'll recess into executive session. 2-minute break?
Yeah.
Okay.
Bye.
And how long for executive session, do you think?
My part's like 10 minutes.
Let's give us 25, so 35, 40 minutes. And no action is
We'll
anticipated.
reconvene at 8 o'clock. And then we'll plan on 35 minutes.
Thank you, everybody. Thank you. Happy holidays, happy New Year.